webinar about natural dentition. Okay, so let me kickstart this webinar, friends, by asking you a question. Does this happen with you? To be very true, it's a rhetorical question because I know it happens, right? In your practice, does it happen that when the work comes back from the laboratory, right, it looks so good? It looks like a prince or a princess there, so charming, glazed, smiling, and then comes this dreaded articulating paper. Why? Because the moment you put it in the patient's mouth, the patient is like, doc, it feels high. And by the time you're done adjusting, that same prince or princess looking crown now leaves your practice looking like an absolute slave. Isn't that the unfortunate reality that we all suffer from? And remember, this is not exclusive to you. If you are having this problem, it is not that God has specifically chosen you to have this problem. Believe me, everyone in dentistry, regardless of where they practice, will face this particular issue. Moving further, in your practice, do you ever come across cases where ceramic is fractured in a PFM crown? We all do. We do monolithic zirconia only to realize zirconia also fractures. More than 1000 megapascals of strength. हथौड़े से नहीं टूटता, लेकिन मुंह में टूट जाता है. Isn't it ironical? Right? Have you ever come across a situation where your patient calls you and tells you, you know what, doc, my cap has come out. No problem. Come over. I will fix it for you. Only to realize when the patient walks into your practice, this is what you see. The entire core, the entire post, everything is gone. Where is it? It is inside the crown, and the crown is in the patient's hand. Unfortunate reality? Yes. Very common problem now. I cement a crown, fits perfectly well. Very nice snug proximal contacts, only to realize 2 months later, there is a highway on both sides. Contacts are open and there is food lodgement happening between the teeth. And all you are left doing is scratch your head. Yaar, kya ho raha hai? Why is this happening? Why is this happening? Guess what? One of the reasons why we as clinicians face these problems is because of the bite. It is because of occlusion. So let me ask you a question. Is occlusion a problem in dentistry? No. Occlusion is a necessity of dentistry. If there is no occlusion, believe me, there will be no dentistry. The problem is understanding occlusion, right? Unfortunately, we've never been trained the right way to look for occlusion through our bachelor's or our master's curriculum, right? So I will dwell significantly through this webinar upon how to understand this occlusion, what should you keep when it comes to occlusion, and what should you remove in the form of interference correction. So understanding occlusion is one mandate of my webinar today. The second mandate, friends, is identification of occlusion, and that deals with using articulating papers. Now remember, there are different shapes, different colors, different thicknesses, different materials when it comes to articulating papers, and it is our own choice from our understanding to choose the correct articulating paper for the designated role. All right, so let's start with the first one, understanding occlusion. Okay, look at this beautiful picture that I put on screen. This is ideal occlusion for the maxillary dentition. Right, now when I say ideal, remember this is a theoretical or a study model. You will never get patients like this. Okay, you aim to go as close as possible to this particular picture. So I remember when I started off understanding and teaching occlusion, what I often used to do is I would take a printout of this, laminate it, and put it on top of my dental chair. Right? It was the perfect example for me to reciprocate when I'm doing any form of occlusal therapy. Now, when I say any form of occlusal therapy, this could be as simple as a filling. Right? This could go onto a crown or a bridge or even a full mouth rehabilitation. The concept, as I mentioned earlier, friends, remains the same. Once you've understood this, once you have made a mental picture of this, all you now need to do is keep copying it. Copy paste, copy paste. Each case is like a stamp. वो दिमाग में छप जाता है. मुझे ये करना है. I have to make sure that I get these points. Any other point, I have to eliminate. So what are these points? I want all of you all to recognize that when it comes to contacts, what we desire is point contacts. We do not want area contacts. All right. The larger the area, the greater the friction. Greater the friction, greater the possibility of ceramic fracturing. Okay. So always target getting small, precise contact points and not contact areas. Okay. Just a hint. This is also a question in the MCQs that you will receive at the end of this webinar. And if you solve that correctly, 6 out of 10, you get 1 credit point from the Indian Dental Association as well. So giving you the exam paper beforehand. Okay. Where should these contact points be? Now look at anterior teeth. Anterior teeth, you ideally want a contact somewhere around the cingulum or the lingual concavity. All right. Why? Because from this point of contact, remember, is your anterior guidance. Okay, so the red lines that you see are nothing but your anterior guidance profiles. On the centrals and the laterals, you want straight lines that are continuous for protrusion. On the canines bilaterally, you want straight lines which are your lateral excursions. All right, now when you look at posterior teeth, I want to highlight the fact here, friends, that when it comes to a premolar, all right, you need 2 points of contact. You don't need more than that. Even if you get 1 point, that is still sufficient. Which are these 2 points of contact? You need a functional cusp tip and a marginal ridge contact. Now look here, you can see the mesial marginal ridge is contacting. This is what you get in terms of occlusal contacts if you have a class 1 occlusion for your patient. If it's a class 2, remember the difference is a premolar width. So instead of a mesial marginal ridge contact, you may get a distal marginal ridge contact, which is absolutely acceptable. What is important is for you to get the palatal cusp tip, which is your functional cusp tip to contact. So remember, in a maxillary premolar, you need a functional cusp tip and a proximal contact. What about a molar? Now, if you think of a molar is nothing but 2 premolars kept next to each other, right? So एक प्रीमोलर के 2 point contact, दूसरे प्रीमोलर के 2 point contact. That gives you 4 points of contact. Where are these 4 points? 2 functional cusp tips, 1 marginal ridge, and 1 central fossa. Right? Now, what's important to remember is this is ideal. Right? If you can get 2 or 3 point contact on a molar, that is also sufficient. Now, what is very important is you should not get any line contacts on posteriors. What I'm trying to tell you here is on posterior teeth, you only want point contacts because these are your static stops. They are ones that hold the vertical dimension in place. All right. A line is something that you desire only and only on the anterior tooth. Right. So these lines that you see on anterior teeth, friends, they are called guidances. Right? Because the anterior guidance is a component of these lines. If you find a line on a posterior tooth, that is called an interference. So I hope you understand the difference between a line on an anterior tooth and a line on the posterior tooth. We do not want lines on the posterior teeth. We only want point contacts on posterior teeth. Let all the lines be on the anteriors. Okay, this is the maxillary arch. Ideal picture. What I would suggest is go ahead and take a screenshot of this on your laptop or on your mobile phone. Believe me, it will help you as a guide whenever you do any form of occlusal therapy. This picture has directly been taken from the starter volume. That is the 2nd edition of the book that I have scripted. Okay. Now this is maxillary. This is mandible. Exactly the same. Right. Anteriors, where you will have your red lines on the incisal edges. Posteriors, you will have only point contacts. Here again, the funda is the same. Functional cusp tip contact goes to the buccal. Marginal ridge contact typically is on the distal. Right? As you can see here, premolar, you have a functional cusp tip contact and a distal marginal ridge contact. Same is for a molar, 4 point contact. 2 functional cusp tips, 1 central fossa, and 1 distal marginal ridge. So this should be your ideal goal when you sit to do any form of occlusal therapy for a mandibular tooth. As I said, this could be a filling, this could be a crown, this could be a partial bounded restoration. Regardless, if it's on the natural dentition, these are the points that you want to keep. Now, why can I not keep points anywhere else? Remember, these are either the highest surfaces of the tooth or the lowest surfaces of the tooth. This is where you want your contacts. Between these two is always a slope. You never want to keep a contact on a slope, because remember, a slope contact will create a slide. It will create a hit and slide in the mandible. Right? So remember to keep contacts on functional cusp tips, central fossas, and marginal ridges. Everywhere else should be removed. Right? Putting both of these together, this is, friends, very, very, very famously referred to as mutually protected occlusion. What is the concept of mutually protected occlusion? It says when I masticate, right, posterior teeth take the brunt of occlusal load and protect the anterior teeth. Okay, but when I go into any lateral excursive movement, or when I go into any protrusive movement, anterior teeth bring about separation of posteriors. And when that happens, elevator muscles relax. All right, so let's understand, during clenching force, posterior teeth take the brunt of the occlusal force and prevent the anterior teeth from getting overloaded. But when I go into any lateral excursion, when I'm chewing food, anterior teeth protect the posterior teeth by relaxing the elevator muscles. That is why they are mutually protective. Remember, in static occlusion, posteriors protect anteriors. Why do anteriors need protection? Because remember, anterior teeth are mounted at an angle. So forces are never perpendicular along the long axis. Remember, posterior teeth, they have wider roots and they can absorb a lot of this load. This is compressive load, right? So posteriors protect the anteriors in static. Anteriors protect the posteriors in dynamic, which is why such an occlusal scheme is called mutually protected occlusion. I hope this concept of occlusion now makes sense, because only once we understand what we are supposed to do would we understand what we are supposed to not do. Okay, so with that is the discussion on understanding basics of occlusion. Let me dwell a little more on the aspect of identifying occlusion, right? And that's where articulating papers come into the picture. So by definition, friends, what is an articulating paper? It is an ink coated strip that is used to highlight contacting surfaces. The key here is contacting surfaces. Unfortunately, क्या है, हमारे दिमाग में contacting surface is only one, and that is occlusal. That's not the case. Contacts are also present proximally. Articulating papers can also be used to gauge proximal contacts. And last but not the least, articulating papers can also be used to gauge if there is any friction in the internal fit of a prosthesis. Okay, so let us understand more on the types of articulating papers. And for this discussion, I will be describing articulating papers under 4 different headings. First is the different thicknesses of articulating papers, the different shapes of articulating papers, the different colors, and last are the different materials. Friends, this is probably the single most important slide when it comes to articulating papers and choosing the right papers. Okay, so what I'm trying to share with you here is purely empiric in nature. There is no documentation, unfortunately, of this. And this classification that I share with you is something that I have come up with purely from my understanding and interpretation of occlusion. All right, so I personally classify articulating papers into 4: ultra thick range, thin range, and the ultra thin range. Now, if I'm talking about the ultra thick papers, these are typically more than 200 microns. And I know a lot of us have these in our practices. Okay, this one is a very common articulating paper that you see in a lot of practices. And guess what? These are extremely thick. I love to call them blotting papers. They are not articulating papers. So where will I use these? My answer is simple: never. I would not want you as a dentist to use this in my mouth. They are just too thick. What will you land up doing? You will land up over reducing the occlusion. Okay. Very frequently with the use of these articulating papers, you will land up removing the entire porcelain and exposing the metal from a PFM crown when that was not needed. Okay, so let's move away from these simple and very cheap articulating papers. Okay, thick articulating papers typically come in the range of 80 to 100 microns, right? And yes, we do use these articulating papers, but where? They are primarily used, friends, for removable prosthodontics. So if I want to do bite adjustment for a complete denture, if I want to do this for an overdenture, if I want to do this, say for a cast partial denture, I would want to use a thick articulating paper, which is typically between 80 and 110 microns. Okay. It is also used for glazed and metal prosthesis. This is a part of what is called as the dual articulator concept, right? And as we move forward, I will show such a case where I have used the dual articulation concept to identify and adjust marks on glazed porcelain and on metal crowns, okay? Coming to the articulating papers that I use most routinely in practice, which is the thin. This is typically 12 to 40 microns in thickness. And when I say most commonly used, it means I'm using this for bisque trial, or if I want to do any occlusal equilibration or natural dentition. So remember, if you're working on natural dentition, you should use articulating papers that lie within this range of 12 to 40 microns. This is because interference perception. Remember, every tooth has a periodontal ligament that has proprioceptors that can identify if there is something hard that comes in your bite, or if there is an interference present in your bite. So this interference perception works at the range of 20 microns, okay? Which is the reason why we work around this range. Now, unfortunately, it's not easy to get a 20 micron articulating paper in the market. You'll either get a 12 micron and then you'll get a 40 micron. That's why I've put this range as thin. And this is what I use, and this is what I would recommend you to use in your practice. So always read kitna thickness hai aapke articulating paper ka before buying it. Don't just buy it on the basis of availability or cost. Okay, there's more to an articulating paper than just that. Coming to the last one, friends, this is ultra thin. These are between 8 and 12. Now that is really, really, really thin. All right, so put this into perspective. If I were to pull off one hair follicle, mera baal lamba hai, hair follicle, if I were to pull it off, typically one strand of hair is about 100 microns thick. So imagine 8 microns. It is extremely, extremely, extremely thin. What that means? That means is it will give me extremely precise contacts. Where will I use this? I will use this if I want to adjust occlusion on implants, because remember, implants do not have the same kind of tolerance like a natural dentition does. There's no PDL there. Okay, so for implants, I would want to use a super thin or an ultra thin articulating paper. If I want to gauge tightness of proximal contacts, when we put a crown and patient says it's feeling very tight, and if you want to gauge the tightness of proximal contacts, you use a 12 micron articulating foil. Okay, and last but not the least is to gauge occlusal contacts, the presence or absence of contacts. And this is typically done with the help of what is called as a shim stock. Okay, what you see there on screen, friends, is a shim stock. It is an 8 or a 12 micron silver foil. It's not a paper, it's a foil. It will not give any form of articulating paper marks. Remember, there is no color on it. Okay, then why do I use it? I use it to check if there is occlusion present on every individual tooth or not when I'm doing a full mouth rehab. Okay, now imagine a scenario where you've put a crown on, say, 4-6. Okay, you've put in your articulating paper, you believe that the contacts are perfect. Your patient is telling you, I'm telling you, doc, this feels high. What do you do? How do you gauge whether your crown is high or not in an objective manner? What you do is you take this shim stock and you place it on the tooth immediately front of your prosthesis. So if I've placed a 4-6, I will place a shim stock on the 5. That's the second premolar. I will ask the patient to bite down, and as you can see on the picture, I'm trying to pull the shim stock through. If I'm able to pull the shim stock through, it means the upper and the lower 5 are not contacting each other, which means the 6 crown is high. I should go ahead and adjust the bite further, right? If shim stock is being held by the premolars, no problem. Your premolars are in contact. Your 6 is also in proper intercuspation. You don't have to adjust this further. So one indication of a shim stock is to gauge the presence or absence of posterior contact. Now, also very important, friends, is when I'm doing a full mouth rehabilitation, I want my posterior teeth to contact heavily. I do not want my anterior teeth to come in very heavy contact, else there will be flaring of the anteriors. Or remember reading fremitus. So I don't want the anterior teeth to kind of go wobbly, right? So there is a concept, friends, called as anterior coupling. What do we do in anterior coupling? We put a shim stock at the back and make sure the patient is able to bite on the shim stock and it holds. It does not come out. But when I put it on the anteriors and ask my patient to bite, the shim stock should slip out when the patient is closing with a very gentle bite. Okay, that is called anterior coupling. But when the patient clenches down with a heavy force, remember, periodontal ligament has a concept of immediate intrusion. That's only a few microns, and that's all it needs to get the anterior teeth to now contact. The same contact holds true for posterior implants, especially a single tooth implant, right? The concept goes like this, okay? No contact in light bite, light contact in heavy bite. What am I talking about? Let me quickly show this to you in the form of this video because you will be able to understand it better. The backend team at Abbott, if you guys could please enable sound so that participants can hear it in case you haven't already done it. My apologies, I had not clarified of this with you guys before. Okay, so let's check this for implant occlusion. All right, the same video that I'm showing you here, friends, is available on my YouTube channel as well. So feel free to go there and watch it again if you missed this in any manner. Okay, I have just gone ahead and completed these two teeth. As you can see, this is a molar implant crown, and this is an Emax for a terminal molar. All right, so this is how you use a shim stock to gauge occlusal contacts.
Samit, please check for audio.
Remember, no contact in light bite. That's why the shim stock pulls through very easily. Now when the patient clenches heavy, right? See the resistance now. Right, I hope that makes sense now. If I check this on a natural tooth, see that even in a light bite. That's a premolar, anterior stop. Right, so this will make sure, friends, that your implant crown does not get overloaded. Remember, most failures in implants tend to happen post-loading. And one of the reasons is because of the periodontal ligament and the immediate intrusion of natural teeth that we do not take into consideration. Right, for all those who've seen that movie Dhamal, right, all four of them are standing in together, and then a question is asked, who did this, and three of them go back, and Javed Jafri is the one who's standing in front, right, and he wonders, मैं आगे क्यों आ जाता हूँ? And Javed Jaffrey, friends, here is the implant. It gets overloaded because natural teeth begin to intrude. All right, so I hope that analogy allows you to understand the importance of adjusting and then gauging the correct occlusion with the help of a shim stock. All right, so a very simple question, and I know this is a question that all of us have in our minds. What is better? Is a thicker articulating paper better or a thinner articulating paper better? Right? I have some pictures that come to you courtesy Bausch. Right? This picture that you see on screen is with a 200 micron articulating paper. I want all of you all to recognize the size of the articulating paper marks. They are quite big. Now look closely. As I go from 200 microns to 100 micron, see the size has gone down, right? I go down to a 40 micron, the size has gone down further. I go down to a 12 micron, the size of contact has gone down further. Let me just reverse that again. So 12 is very small, 40 is a little bigger, 200 is bigger, and 100 is bigger, and then 200 is very large. So as I come down the size of articulating papers, what happens is the size of articulating paper mark that is left on the prosthesis and the natural tooth also decreases. Right now, my strong belief is the smaller the size of contact, the more precise the marking is. I will know that much better. This is the point that I need to adjust, which means there is greater control that I have on final anatomy. If I mark with a very thick paper, I will get a very large contact. If I get a very large contact, I'm going to take my burr and drill the entire contact away. Now what happens is the crown that came with beautiful cuspal anatomy now has become flat. Okay, so don't use thick papers, thinner papers. Why? Because thinner paper marks will leave better anatomy, which will give the patient better masticatory efficiency. You will not have a scenario where after cementing a crown, your patient tells you, doc, I don't think I'm comfortable eating food from this side. Why? What happened? The crown is fitting perfectly well, but the contacts, right, are no longer the way they are supposed to be, because the anatomy of the natural dentition, which has a cuspal pattern, is unfortunately been lost. So those are the advantages, friends, that we get out of using a thinner articulating paper. Now, what are the drawbacks that come from using a thicker articulating paper? The moment you put a thick articulating paper, especially if you put it one side, right? The moment you put articulating paper on this side, it's not unnatural for patients' masticatory reflex to automatically take the mandible towards that side, right? So what happens is with a thicker paper, the masticatory reflex is activated, and thereby you may land up getting pseudo contacts. They are not true contacts, but you unfortunately land up grinding them away. Added, when you use thicker papers, the resistance to chewing that a thicker paper gives creates frictional contacts. Now, frictional contacts are typically large but light. Now, when you have light and large contacts, you are just not sure whether that is a true contact or whether it is a pseudo contact, and that tends to happen with these thicker articulating papers. And last but not the least, remember, thicker articulating papers have a tendency to get wet very easily, and if they get wet, they tend to tear off. What is the advantage with thinner papers? Thinner papers are often made of a foil material that's interposed between them, so they don't tend to tear as easily. Remember, we saw the shim stock earlier. Now the shim stock is a full foil. If I were to keep a paper and try to pull the paper will tear. A shim stock, because it's a foil, it does not tear, thereby allows me to use it like a feeler gauge. Okay, so whenever possible, use thinner articulating papers. Okay, here I am enlisting a few very famous companies with articulating papers that I personally have in my practice. I like to keep different thicknesses with me, because if you call it, it's an obsession for me to go down and get the occlusion absolutely right for every individual case. That's because probably I understand of the implications or the negative impact that will occur in the patient's life if I were to leave an interference in the patient's mouth. So am I asking you to buy all of these? No. Right? Which ones should you buy? You should have 100 micron with you. If you are doing any form of removable prosthodontics, 100 micron is what you will use there. Everyone who is doing crown and bridge dentistry should at least invest in a 40 micron articulating paper, right? 40 microns is easily available today from the company Bausch. Please go ahead and buy it. They are not very expensive, right? At least when you compare it to the fact that if you leave a problem in the patient's mouth, it is going to cost the patient a lot more.
Dr. Moise, yeah,
Yes.
testing.
What I'm sharing here on screen with you are the different companies and the different thicknesses that I personally have in my practice, right? Now, I'm not asking you to invest in all of these. I have done it because I am a little obsessed with respect to getting the occlusion right for every individual case, okay? But what I want all of you all to do is make sure that in your practice, you have at least 3 different thicknesses. The first one is 100 microns because all of us do some form of removable prosthetics at some point in our lives. So 100 micron is what you need there. I would want you guys to invest in 40 microns because 40 microns is going to be used the most, be it natural dentition or be it any prosthetic rehabilitation that is fixed. It could be PFM, it could be zirconia, it could be Emax, doesn't matter. 40 microns is what you would want to use. The next is a 12 or an 8 micron shim stock, right? If you have these 3, you should be able to do all forms of occlusal
Doctor,
adjustments. Yes, Preeti,
Doctor,
please.
just hold on. Samir, please check. It's not moving.
Is
Yeah,
the
Samir.
slide not
Now.
moving or am I not audible?
No, you're not
Slides are not
audible.
moving.
And you're not audible, and the event is paused for around 20-30 doctors have told me.
I think it is
And
started. I'm getting
it's now
comments
live.
now.
It's now live. It's now live.
Now it is live. Doctor, you can start.
Okay,
Yeah.
would you want me to start with this slide all over again?
Previous slide. Doctor, previous slide. Can you start with, please?
Previous slide, this one.
Yes. Yeah, from here you can start.
Okay, all right, guys. Apologies for that short interruption. As much as digital technology brings us together, we all understand that there are a few shortcomings to it. So apologies for the same. But I'm going to make sure I repeat this section all over again in case you guys have missed this. Right? This is a discussion on whether thicker articulating papers are better or are thinner articulating papers better. So here I'm showing you pictures courtesy Bausch. These are pictures that will show you, friends, of the size of articulating paper marks on the basis of a thickness. Right. So first picture that you see on screen here is 200 microns. I want all of you all to understand that a 200 micron articulating paper will give you relatively large thick marks. Okay. If you go down in size to 100, as you can see on screen now, the size of the contact has decreased. I go down to 40, it's decreased further. I go down to 12, it is decreased even further. So from a thicker paper, as I keep coming down in size, okay, the size of mark that it leaves on the tooth or the prosthesis also decreases. Okay, so the smaller the mark, remember, the more precise the location of contact. Now, if I were to use a thicker articulating paper and I get a large area contact, I might land up grinding the entire portion away. And then I land up with an infra-occlusion on that tooth. I don't want that. Okay. A thinner articulating paper will give you more precise contact location, allowing us to control the anatomy better and also give our patient better masticatory efficiency. Okay. Now, if I have a thicker articulating paper, the biggest problem is that it triggers a chewing reflex, which means if I put a thick articulating paper here, remember patient tries to close down, there is something very thick in the middle. So this side may not contact at all. And if this side is not contacting, automatically the patient starts moving the jaw towards the side where you put your articulating paper. And that will happen with a thicker paper because, as I mentioned, it tends to trigger the chewing reflex. Okay. Thicker articulating papers will also create frictional contacts. Frictional contacts means a thicker paper will land up giving a mark even in areas where there is no physical contact, which means there will be a pseudo contact. Once again, you will land up grinding that away when you should not have. And last but not the least, thicker papers tend to tear easily because if they get wet, especially towards the terminal molars, right? These are papers, they will soak and they will rip apart. Thinner papers are not papers, but they are foils. So the advantage with a foil is it's just like a sheet of cellophane. It will not tear very easily. So when I use it in the form of a shim stock, paper will tear. Articulating foil will not. Okay, so that's where a thinner paper is always better than a thicker one. Okay, here I'm sharing different companies that have different thicknesses, and these are the ones that I personally have in my practice. I'm not asking you to buy all of these. I'm telling you what I have, right? Because I am a little obsessed when it comes to getting the absolute precision when it comes to adjusting every single crown in the mouth. That's why I'm a little finicky and I have so many. The first one is 100 microns. Why? Because all of us do removable prosthodontics. So that's a must. 40 microns, an absolute essential because we all do crown and bridge dentistry. 12 microns is a must if you are doing implant prosthodontics and if you want to gauge the occlusal contacts with the help of a shim stock. So 100 micron, a 40 micron, and a 12 micron. If you have these in your armamentarium, you are sorted for almost all forms of prosthodontics. So remember, don't just remove an articulating paper and start using it. You have to understand that there is a purpose behind the design and the thickness of the same, and this should now be used in a very planned and a systematic manner. Let me highlight to you one particular brand that lately I have become a big fan of. If you've heard me before, you've heard me talk about Bausch articulating papers on multiple portals and multiple platforms. Let me tell you, I don't benefit the slightest bit by talking about them. The reason I do is because I use them, I like them, right? Now, recently, when I say recently, it's been about a couple of years that I have started using articulating papers that come from this company, Troll Dental, and it's called Troll Foil, right? They come only in unilateral pieces like these. Okay, and what I love about these articulating papers is they are extremely thin. 8 microns is what the company claims. Okay, but they mark even in a wet environment. Now, normally when you have saliva, articulating papers don't mark. Right, that is where Troll Foil is a big tick in my world because it works even in a wet environment, and Troll Foil gives marks even on glazed ceramic crowns. So for all of y'all who attended webinar 2 of this series, which was about tabletop posteriors, my articulating paper of choice for almost all those cases is Troll Foil. Why? Because the surface is glazed. Remember Emax, I cannot adjust or gauge the bite before bonding. Once I've bonded, and if it's a glazed surface, normal articulating papers will not give marks. Your patient will tell you, doc, it feels high. Your articulating paper is not marking, so what do you adjust? And that's where my savior grace has been Troll Foil. Let me show you mutually protected occlusion on an anterior full mouth rehabilitation case. Okay, so look here. The blue dots are your centric stops. The red lines that you see on the centrals and the canines are your guidance profiles. And remember, this is glazed Emax that is bonded, right? Even on bonded ceramic, a Troll Foil gives me such beautiful marks. Troll Foil also comes in a blue and a red, okay? Yes, availability is a slight concern. Having said that, there are dealers for this in India as well. Okay. So moving forward, a common question that I am often asked, right? Sir, what is the thickness of this carbon paper? And my answer is simple. I'm sorry, I don't know. You know why? Because I don't care. This is not an articulating paper. It is a copying paper. The problem with this is the fact that it leaves a lot of smudge marks. Areas that do not contact also will mark blue. So what do? If you see blue, you will grind. You will grind till you see no blue. And by that time, you have landed up leaving the entire occlusion out of contact. And guess what? It will still continue to mark blue. So please, if you value your work as a professional, if you value the trust and faith that your patient puts into you, please stop using these cheap papers. Thoda invest kar lo. Add that cost to the patient's procedure. I'm not saying spend money from your pocket, but deliver good dentistry. Compete with your next door dentist on the basis of quality of work, not just the price of your procedures. Start doing good work so that we as human beings start feeling better. And believe me, these patients will start referring more work to you because they are happy with what you've done for them. Added, your operatory is not filled with repeat work, is not filled with patients who have complaints, but filled with potential new clients. Isn't that what we all want in a competitive world that we today find ourselves in? Articulating papers will help improve the quality of dentistry and thereby influence our own lives professionally and personally in the long run. So please put in a little more investment into it because they are genuinely important, right? When it comes to shapes, articulating papers are available in 3 different shapes. Okay, the first one is the most common one that we all have in our practices, and that is strips. Okay, the next one is your horseshoe design. Where should you use strips? You should use strips, friends, if you're doing only quadrant dentistry, which means you're working on one tooth on one side, right? Feel free to use strips. Where should you use the horseshoe design? If and when you are doing bilateral dentistry, which means you're doing a crown here and a crown here, or you're doing a bridge here and a bridge here, or you're doing a cast partial that goes both sides, or if you're doing a complete denture, if you're doing a full mouth rehab, that's where you want to use the horseshoe design. Single strip में वापस कई बार क्या होता है, you put this articulating paper here, patient takes the jaw towards that side and closes. Patient thinks there is food. What do you do when there's food on one side? You start chewing towards that side. So these are again patients where you should use the horseshoe design, because the moment you put a horseshoe inside, remember, the patient now starts closing together bilaterally, right? It's human nature, right? Starts closing in the midline, right? So that's how you understand when to use a strip as against a horseshoe design. A third design is something that's called as sheets or rolls. These are in meters. Articulating papers also come in meters. Kapda aata na वैसे. These are, however, ideally used only in laboratory procedures and on articulators. So I'm not going to dwell too much. Strips and horseshoe designs are the ones that we as clinicians should most routinely refer to when we are doing crown bridge dentistry or full mouth work as well. Okay, next important is color. Now, there were years before articulating papers available in multiple colors. All right, so I remember myself at some point having blue and red, which is common. Then there is black, and very common was green, right? And this was very famous earlier. Today, it's very difficult to get these papers, these colors. Why? Because earlier, there was a lot of gold crowns, a lot of amalgam dentistry. So a green articulating paper would highlight on these surfaces very much. Because the use of metals per se in dentistry has significantly decreased, today articulating papers exclusively come in these 2 colors. Standard is blue, standard is red. All right, now when would I want to use a blue as against a red? I want all of you all to go back to that picture that I showed you earlier of mutually protected occlusion. Remember, we had blue dots and we had red lines. So my basic funda in my practice is get your static occlusion with blue. Why? Because blue will give you very nice, crisp, clean looking contacts. Your guidance is you should get with the help of red. So static with blue, dynamic with red, right? That's how I work in my practice. Having said that, you also have articulating papers that are red on one side and blue on the other side. So where will I use that? If I were to do a single crown, what I will do is I will put the articulating paper such that the blue is towards the crown so that I can get static marks with it, and then turn the articulating paper over and then ask the patient to go right, left, forward, back. So I will get static with blue, dynamic with red in the same articulating paper. Okay, so if it's blue on both sides, I will get a mark above and below in blue. If it's blue and red, only on the prosthesis that I am working on will I get the blue contact. Okay, so if you're doing an upper and a lower crown together, use an articulating paper that is blue on both sides and red on both sides. You'll get both marks together. If you're working on a single crown, then you use an articulating paper that is blue on one side and red on the other side. You can simply flip the articulating paper over and adjust the occlusion. So that's how different colors can be or should be used. Okay, next we come to different materials. All right, now this is to do with the thickness of these articulating papers. So you have paper, you have foil, which is what we've discussed. You also have silk. Now silk, mind you, is again something that laboratories are supposed to use. So I will not dwell much into that. But remember, if you have thinner articulating papers, that is 8, 12, and you also get a 16 micron, which is called as gnathological papers. Okay, again, not something that I would want you to invest in or use because we no longer follow gnathological principles. But when it comes to 8 and 12, how are these things made? They first have a foil, all right? And then one side is color coded. Okay, so the foil typically is thin and then the color coat comes on top, and together it gives you 12 microns. If it's only foil, it's 8 microns, it becomes a shim stock. If you have color added on one side, it becomes 12 microns and it now becomes an articulating foil because you have color on one side and you have foil on the other side. Okay, so 8, 12, 16 are always foils. 8 micron is characteristic shim stock. 12 microns is what we use for proximal contacts. And if you want to gauge occlusion on an implant prosthesis. 40 microns, which is for natural dentition. It has a specialized paper in the middle, which is 20 microns. And then on either side, there is a 10 micron layer. And the beauty about these Bausch papers, okay, these are very, very nicely designed because they have these small balloons of color, right? They are called microcapsules. Okay. Now, this is a brilliant video that will help you understand how these capsules work. The moment there is antagonist tooth contact, the capsule ruptures. As it ruptures, it leaves marking on the tooth in contact. What's the beauty about this? Exactly where there is a contact, there is a mark. So the possibility of pseudo marks being created is significantly decreased. That is why I am a personal huge fan of the 40 micron. It's called RT Check, which is from Bausch. Okay, now if you have thicker papers, right, that's 80, 100, 200, these typically not only have a foil or a paper or microglobules, but they have tubes, right? They have entire channel of tubes that are filled with color. And this one from Bausch has an adhesive that's called transculase present on it. It's like a bonding agent. वो कई बार हम कुछ चिपकाने जाते तो हाथ कैसे चिपकना लगता है ना. There's always a sticky adhesive that's left on your fingers if you were to glue something, right? So this is like that bonding agent that is present, and this is mighty useful when you are working with ceramic or glazed surfaces. Okay, so what you do here is you have the patient bite down onto a thicker paper. It leaves these large areas of contact, and the surface, as you can see, has a yellow hue around it, right? That yellow hue that you see around is nothing but the transculase. Okay, now this is where the concept of progressive color transfer comes in. Let me show you a picture of what a progressive color transfer is, right? Just highlighting one contact for you. It's called the bullseye effect, right? I'm sure we would have all at some point in our lives seen these kind of contacts. Okay, just outlining things to make them a little more easier to understand. That's the larger mark that you see outside. And then there is a small punctate area in the middle where you don't see articulating paper mark. Okay, and an important question to ask ourselves is, where is the actual contact happening? Remember, the progressive color concept works on an area where there is contact. It does not leave a mark, but it leaves a mark on the periphery of the contact, trying to tell you this is an area that is close to contact. All right, so the area that is marked or highlighted in yellow here, friends, okay, is the area which is close to contact but not physically in contact. When you look at the orange that I have highlighted inside, where there is no color transfer, that is the area of true contact. So if there is a high point present, or if there is an interference present, what will you grind? You will only and only grind the area in the middle. You will not grind the colored portion. You will grind the portion where the color is no longer present. That is the concept of progressive color transfer. And the burr that you see here is called the CA 1.6F. CA, if you were there as a part of the first webinar where I described this advanced burr box to you, CA, friends, stands for ceramic adjustment burr. Now remember, when you're adjusting occlusion, you don't just draw any burr in your kitty and start adjusting. You have to respect anatomy. And that is why there is a specific shape that you see here, which is ideally supposed to be used for adjusting ceramic. And the fact that it's a red ring burr, which means it is a finishing burr. Okay, you don't have to grind contact away. You have to refine the interference contact. Okay, so CA 1.6F, that is the particular burr that you see inside the kit, which is supposed to be used for adjusting contacts. Now remember, this burr can be used if you're doing PFM, zirconia, or composite. The same burr, the same design anatomy can be used for different types of materials as well. Okay, moving forward, look at this contact here. What do you see here? Okay, only the middle area. Remember, the area where there is no marking is the area that you need to adjust. Please don't go and grind the entire contact away. This is different from regular articulating papers, because regular articulating papers kaisa hota hai? Darker the mark, the heavier is the contact. So you'll end up grinding the entire contact away. Progressive color transfer is present with thicker papers. Okay, and there you only grind the bullseye. You don't grind the marking away. Okay, look at this contact that is present here. If you look at this contact closely, there's only a yellow mark. There is no orange in the middle, which means this is an area that is close to contact, but not actually in contact. So will you grind that? No. You will only grind areas where articulating paper has not left any mark. I hope it's clear, this concept of progressive color transfer. Where do you use this concept of progressive color transfer? If you are working on glazed ceramic crowns or metal crowns. Right, and this is where this video will help clarify this aspect for you. Okay, here you can see what have I used. I have used first Bausch 100 microns. This is called Progress 100 because it creates that progressive color transfer effect. Okay, now what I want all of you all to recognize is there are three primary marks that it has created. Okay, it has created a contact here, it has created a contact here, it has created a contact here. Okay, now I will not start adjusting right now. Why? Because this is 100 micron. Remember, I am supposed to adjust occlusion at 40 micron. So what will I do? Once I have used a blue 100 micron, I will now use a red 40 micron. Okay, look at the contacts that a red articulating paper has now left. It has left a contact here, which is a functional cusp tip. Remember, mandibular premolar, I want a functional cusp tip contact. And it has left a contact on the distal marginal ridge. Beautiful. I want these as my static stops for a mandibular premolar. Now the question arises. There is a third mark here, which is on a slope. If it's on a slope, do I want to keep it or do I want to remove it? I should not remove it. Why not? Because it's only 100 micron that has created that mark. 40 micron has not created a mark over that surface. What does that tell me? It tells me these two contacting surfaces are very close to each other, but they are not actually in contact. What will happen if I remove this contact away? If I remove this contact away, my patient might tell me, I'm not able to chew as effectively from this side as I used to. Why is that? Because occluding surfaces are too far away from each other, decreasing the crushing efficiency that cuspal slopes or cuspal inclines provide to the dentition. All right, so that's basically, friends, the concept of dual articulating papers, where you first use a thicker articulating paper followed by a thinner one. And remember to do this only on glazed ceramic crowns or metal crowns, because regular articulating papers will not mark because the surface is so very smooth. Okay, let me quickly show you one such example of a case, because it has a little more complication than a straightforward prosthesis. Why? This is a overlay. Again, for everyone who attended the second webinar, you will understand the concept of partial bonded restorations. This is an endodontically treated first molar. Buccally, as you can see, this is the junction between porcelain and the underlying tooth. Lingually, here again, you can see the junction that I have highlighted. Okay. Now, if you look at the second premolar, it's a DO that has been restored in the form of a composite direct restoration. If you look at the 7th, there is a class 1 composite restoration. Right? So what's the complexity in this case? The complexity is I have natural tooth to work with, I have composite to work with, and I have ceramic to work with. And the ceramic is glazed. Because it is glazed, what will happen? My regular 40 micron will not mark. Right? Because glazed or extremely smooth surfaces are involved, I know in my head I have to use the dual articulation technique. So what do I do first? I first go ahead and I use my Bausch 100 micron articulating paper. As you can see, it has left relatively large areas of contact. But remember, I am not to adjust 100 microns. I have to adjust with a 40. So I will use a contrasting color for the 40 micron. Now you can clearly see areas that need to be adjusted. This is the beauty about these contacts. Right here you can see there is a line contact, there is an area contact. I do not want area contacts. What do I want? I only want point contact. So what will I do? With the help of this burr, which is the CA 1.6F. Remember, CA stands for ceramic or composite adjustment. 1.6 stands for the widest diameter of the burr, and F stands for the fact that this is a red ring or a finishing diamond burr. And this is where I ideally want to leave my occlusal contacts. Okay, as you can see, I have functional custip contacts and marginal ridge contact. Functional custip, functional custip, functional custip. Again, functional custip, central fossa. There is one area contact that I do not like. Can you see this lingual area? Now, if this were to have marked only and only with blue and not with red, I would not worry about it. But because it has left a red mark, this is a concern area for me. This is an interference. So what am I supposed to do? I'm supposed to take the burr and grind that off. But remember, if you grind ceramic, you also have to go ahead and polish the same chair side. For the same, friends, I use a burr that comes from the company Kenda, Kenda. These are silicon carbides. They are used to chair side polish ceramic restorations. Okay? All right. Next, let us talk about the importance of the shape of an articulating paper mark. Yes, that is also important, and it has a lot of clinical relevance and value. All right, so let's look at this picture here. Let's look at the second molar. This is a nice round contact on a functional cusp tip. Very desirable. Let's look at this contact. This contact is slightly ovoid. So what will I do? I will go ahead and trim a little bit only so that I can get a rounded contact. Where is the biggest issue with this area? It is right here. You can clearly see that there are multiple contact marks. More importantly, this contact is largely ovoid and is on a slope. It is not on a cusp tip. This is where I want the contact to be. But the contact, as you can see, is a line contact. I do not want lines at the back. So what will I do? I will take the burr and selectively reduce only the inclined contact, and I will maintain the cuspal contact. That is how you get your dots at the back, and automatically the lines will go towards the front. Okay, so this is the importance of the shape of your contact. All right. Okay. A few tips that I would want to share with you guys that will help improve your contact tracing. It sounds funny, right? Because contact tracing is something that we started associating with completely a different issue that we have in our lives. But if you're tracing contacts intraorally, which is the topic of discussion here for today, remember dry surfaces will always mark best. So when you're talking about dry surfaces, friends, this is air drying, not just cotton drying. So don't just take cotton and dry the surface, right? Take air from your three-way and blast the natural dentition or the prosthesis. Make sure the surface is dry, and then use your articulating papers, because they will give you very nice marks. Next, if you are not able to control salivation, what you could do is coat your articulating paper with a very thin layer of Vaseline. Now, why do we do so? Remember, Vaseline is a water repellent. Okay, so if there is saliva on your tooth and there is Vaseline that's present on your articulating paper, the moment the patient bites down, the Vaseline will first repel the saliva away, allowing your articulating paper to physically come in contact with the tooth, thereby registering a mark. Okay, so this is something that you could start doing in your practice, but tends to get a little slippery, right? So we know Vaseline is not the best material to work with. So be careful of that. You should not be using water soluble jellies. It'll make no sense, because saliva will not be repelled by those jellies. Okay, rapid tapping always helps give precise marks. So कई बार क्या होता है ना, we put articulating paper in and we tell the patient to bite. So what does the patient do? Patient's taking the mandible everywhere, right? And never is the contact in the same place. What will you get? You will get large area contacts that are very light. That's not what we desire. Okay. On the other hand, rapid tapping will give you smaller and darker marks. Okay, as a part of my lectures and my courses, at least those ones that were in-person event, where I would stand in front of a podium or a stage, and the audience would be on the opposite side. I used to play this small game with everyone. I'm guessing a few of you all have probably played that game with me. I would tell them, put both your hands out, okay, and then give me an ovation, and everyone claps. Okay, and what happens when you clap? Right, let's understand. These surfaces are contacting. Okay, but when you clap slowly, the surfaces never contact with heavy intensity, and they never contact in the exact same place again. Okay, on the other hand, if you were to do rapid clapping, look at me, rapid clapping. What am I doing? I am leaving a contact in the exact same area. More importantly, the repeated hit at a greater intensity will give me smaller but darker marks. When I have smaller and darker marks, what do? In my head, I bring up that picture of mutually protected occlusion. Where did I want those dots? I will maintain those dots. Where do I not want those dots? I will grind that away. Thokotali. Remember, dry surfaces, thin articulating papers, rapid tapping. These are the keys to get good, crisp articulating paper marks that you can easily go ahead and identify, and then of course go ahead and adjust as well. And last but not the least, remember, patient position matters. So whenever you are adjusting occlusion, it helps to start with the patient in a reclined position, right? Tap, 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 all excursive movements. But before leaving your patient or sending the work to the laboratory or after cementing a crown, always have the patient seated up in the chair and simply ask the patient, does your bite feel the same? Does it feel different? Literature says half your patients will say the bite feels the same. Fantastic. और काम करने की जरूरत नहीं है. इतने पैसे में इतना ही मिलेगा. But if your patient tells you my bite does feel different, please go ahead and adjust the bite in a seated position, because remember, this is to do with condylar position and gravity. In a reclined position, the condyle is pulled back, so the bite changes. In a seated position, which is the position that we normally eat our food in, okay, seated position, this is where you have to go ahead and gauge the occlusion one more time. So these are small tips that I would want you to remember when you are working with articulating papers. Okay, now remember, I have shown you multiple different designs, multiple thicknesses, multiple shapes, and materials of articulating papers that are available to us at our disposal. It is up to us, friends, to choose them correctly and to use them prudently. Why? Because our patients deserve it. Okay, let me bring to perspective the implications that may happen out of one solitary interference. And this is a beautiful illustration that we got prepared as a part of the master volume of my book, Clinical Fixed Prosthodontics. Let me bring to attention here, this is an asymptomatic patient who is predisposed to a temporomandibular joint problem. Now, what does the meaning of a predisposed patient mean? There are always some patients, if you leave the smallest of interference, they will have major issues. There will be others where you leave major interferences and their body will adapt to it. Every individual has a different threshold or resistance to adaptation. So if you have a patient who is predisposed to break down, a minute interference can create a cascading effect. It's just like the dominoes effect. One domino goes down and the entire series begins to fall apart. So look at this illustration closely, right? You have elevator muscles. You have the masseter, which I have given a single plus, and you can see it's red in color. You have the temporalis, which is plus. You have the superior lateral pterygoid, which is plus. But the most important muscle in this picture is the blue muscle, which is the inferior lateral pterygoid. Look at the fact that it is negative. Negative means it is relaxed. Why? Remember a very, very, very good textbook that we all had in first BDS. It was red in color. B. Chaurasia. God bless that man. I mean, I wonder what would his state be with all the COVID that surrounds us today. Okay, anyways, we remember reading muscles of mastication, and we have the elevators and we have the depressors. So we have the masseter, the temporalis, and the medial pterygoid, which are the elevators, that you can see is plus, and we have the lateral pterygoid, which is the depressor, which is minus. This is a mutually coordinated system. When the elevators are active, the depressor is inactive. Now look closely. One crown that comes from the laboratory and I place it there. One single crown. My patient tells me, doc, अजीब लग रहा है, ऊंचा लग रहा है, it feels high. What do I tell my patient? It's most unfortunate, right? We often land up telling our patients, "Are, don't worry, give it 2 days, it'll all settle down." Guess what? This settling may actually have implications beyond our realms of understanding in that patient's life. You know why? Because in an attempt to accommodate for that one interference, the individual completely changes the bite. I want all of you all to look closely at this area. This is a single point of contact where all the other teeth are no longer meeting. So if there is no contact between teeth, an individual cannot eat food. So what does an individual land up doing? Individual lands up clenching and grinding on that first point of contact. And this is where, friends, look closely at the screen now, a hit and slide occlusion sets in. Here you can see all the teeth are beautifully intercuspated. But what has happened to the muscles? Look at these muscles. These muscles that were earlier light red have now gone dark red. But more importantly, look at this muscle, which is the lateral pterygoid. From a single plus, these muscles have gone into double plus. But most importantly, the inferior lateral pterygoid has also gone into spasmodic contraction. You know what has happened? Coordinated musculature has become discoordinated. More than discoordinated, what has happened is hyperactivity. Now remember, friends, when you go to sleep, muscles are supposed to rest. Unfortunately, it is during sleep time that an individual tends to clench and brux the most. Okay? If the masseter is being clenching all through the night, you know what's going to happen to this person when he or she gets up in the morning? They're going to have a headache. If an individual gets up in the morning saying, I don't think I have slept enough, this is because the muscles have not relaxed through the night. You may have slept 8 hours, but the problem is not with quantity of sleep. The problem is with the quality of sleep. This is because there is muscle incoordination. Look closely once again at the screen. This is where everything is normal. One interference goes in and there is hyperactivity. Once again, this is static contact. Over a period of 2 days, as the occlusion settles, the entire mandible swings forward. I would want to ask all of you all a question. Do you know what happens during these 2 days when so-called occlusion settles by itself? The lateral pterygoid muscle has become spasmodic. Simple analogy that I want to give you guys. Imagine that you're going through a very straight road, no traffic, you're going nice and fast. All of a sudden, there is a pothole, right? And what does your car do? Your car hits the pothole. You know what? Your mind has subconsciously registered there is a pothole there. Imagine next morning you're going down that same road. Will you hit that same pothole? You will not, because your brain will remind you there is a pothole. So what will you do? You will change the path so that you can avoid that pothole. That is exactly what the mandible also does. First day, there is a hit and slide. There is a hit and slide. There is a reminder for the brain that there is an interference. There is a new contact that is not desirable. So what will happen? The brain will subconsciously register there is a pothole there. What will now happen? The lateral pterygoid muscle will change the path of mandibular closure to avoid that interference. In 2 days, occlusion has settled. But guess what? The entire bite has now gone into a completely different direction, causing new problems elsewhere. I always say interference is like a hormone. The origin is somewhere else. The effect is somewhere else. If you see a patient whose anterior teeth are retreated and you're thinking of doing porcelain laminates, think again. If enamel was broken down, how will your porcelain survive? If you want those anteriors to survive, first look at an interference that is present at the back. Once you eliminate that interference, restore your anterior teeth, they will survive. Guess what, friends? We are talking about one interference that changes an asymptomatic patient into a symptomatic one. One interference. As I love to say, Nana Patekar says, ek machhar. Just one interference is all it takes to spoil an individual's life. Let me share with you implications of one interference. I have clustered them at the dental periodontal level, muscular level, and joint level. And I'm simply going to enlist these points. And believe me, the list is long. And it took me time to imagine of all the implications and put them down, but I have done that so that we as clinicians can understand what we are creating in our patients' mouths when we tell them, ye settle ho jayega. Remember, first thing, there could be tenderness on biting. With one high point, your patient will tell you, I'm feeling a little pain on that tooth. That pain is not because your root canal was not done properly. It's because the crown is high. The immediate consequence that will happen is mobility. Remember reading TFO, trauma from occlusion. The first sign is widening of the periodontal ligament because the tooth tips itself in an attempt to accommodate by stretching of the proprioceptors. You could have migration of the offending tooth. The entire tooth could move out of contact. Isn't that what happens when contacts open up between teeth and there is food lodgement? It's telling you the occlusion was faulty, and that occlusion need not be static occlusion, but also dynamic. So stop using blue articulating papers alone. Start using red articulating papers as well. That will make sure contacts do not open, because PDL will not get stretched. Okay. You may have wearing of the antagonist tooth. Remember, if you put a ceramic crown here in high point, the antagonist, the enamel, which is the softer the material, will wear away. These patients could complain of sensitivity to hot and cold, and you would wonder to yourself, root canal ho gaya hai, fir kyun sensitivity ho rahi? It's because of an interference. There could be fracture of the prosthesis. Isn't that what we commonly see, ceramic fracturing? It's the weakest link. It fractured. Okay. If the abutment is weak because you've done a root canal and then you've done a full crown preparation, there's nothing remaining, your abutment may fracture. There could be a possibility that the antagonist tooth may fracture. There could be a cusp that goes off, or there could be a vertical crack, and you have to extract the antagonist. Okay, that could have been prevented. There could be mobility, migration, or tenderness of the offending tooth or the antagonist tooth. There could be gingival recession. Remember, secondary trauma from occlusion is where you have bone loss and the gingiva receding. You could have abfractions. Those are your class 5 lesions. You could have development of bony exostosis. When you see tori present, this could be because there is excessive force present on that particular tooth, and nature is trying to protect by creating a buttressing bone formation. An individual could find it difficult to identify the correct bite, or could simply have difficulty in choosing. So much could happen at a dental level. At a muscular level, the patient may develop hyperactivity or pain in masticatory musculature. This will either result in enlargement of a muscle. Don't we see individuals who have very large masseters, or you see the temporal is bulging each time they clench? These are hyperactive or hypertrophic muscles. An individual's mouth opening could change. Either it's a trismus-like situation, or the range of movement or the direction of movement gets altered. Patient may have a spastic response there. Patient may even develop headache, neck ache, backache, shoulder ache. I mean, there is so much research on kinesiology that is present today, which is all about the science of muscle movement and balance. And I will quickly share a slide with you because it baffles me, of so much that can happen because of one interference that we leave in the patient's mouth. What can happen at a joint level? You could further have patients who have tinnitus, vertigo, and orofacial pains. I mean, it's weird to think about it. Why would a patient get vertigo because of an interference? Yes, it happens. Because remember, the joint is very close to the middle ear. And the middle ear is the organ that is responsible for balance. And an individual may develop vertigo because of a high point. Right? And I say this because I've genuinely treated patients who came in with vertigo, and we've corrected their bite to correct their vertigo. It's absolutely astounding how the connection works. Okay, it's not uncommon because of one high point. Your patient may develop a click because of a disc displacement. There will be severe pain if there is retrodiscal compression, if there is perforation, if there could be bone-to-bone contact and crepitus, or worst case scenario, degenerative joint disease. And remember, a lot of these happen so-called in an iatrogenic manner. हम जानबूझ के तो नहीं करते, हो जाता है. And a lot of these patients suffer a lot because no one's able to identify what the problem is. There is so much stress in their lives that the stress causes depression. You know why? Because it's unfortunate these patients get referred to different forms or different branches of medicine. They go through blood tests, they go to brain scans, and eventually they'll end up going to a neurologist or a neurophysician or even a psychiatrist who says it's all in your head. And they'll end up taking medication to treat the problem because no one has been able to identify there was one, because no one was looking at the bite, which is where the problem lies. Remember, if you change the bite of an individual, you'll end up changing the head posture of an individual. Okay, and what are the implications of change in head posture? Look closely. With one interference, the individual might land up slightly tipping the head. It seems like innocuous, right? अच्छा, इससे क्या फर्क पड़ता है? But if there is the slightest tip in the head, remember your head is anchored to the spine with your atlas and axis. Remember C1, C2, very important vertebrae that bring about a change in the shoulder orientation. And if that happens, the body automatically brings about a reflex change in hip position. That brings about a change in the knee position. That brings about a change in the foot position. Imagine someone who's suffering from a pronation in the foot, which is very common. The cause of that may be present in the bite being faulty. Astounding. Imagine someone who's suffering from a unilateral knee problem. The problem could be the bite. Someone who has a hip related issue, someone who has a shoulder related issue, someone who has cervical spondylosis. The problem could be a bad bite. I have a very simple question to ask you. Friends, which is the highest joint in the human body? It is the joint that we as dentists have the responsibility of catering to. It's your temporomandibular joint. It's the joint that sits at the apex of the body. And if there is a problem with this joint, it will have a cascading effect that goes down. And you will not even realize the implications that you will cause to the patient if you tell them crown will settle. Would you want this to yourself? Would you want this to any family member? No, right? It's up to us, friends. It is up to us to either create a problem for the patient or to identify a problem and correct it. We as dentists can have immense impact on the lives of our patients. Stop thinking of ourselves as tooth doctors. We are not just dentists. We treat the entire face. Friends, teeth at the front, joint at the back, it's the muscle in the middle, which is the power factor. And Dr. Peter Dawson, someone who I believe a lot in, very, very, very beautifully says, physicians of the masticatory system, that's what he calls us, elevates ourselves to the next level, right? Physicians of the masticatory system must understand how all the interrelated part of the system work in harmony. Why is this important? Because if any one part of the system goes out of harmony, all the other parts get affected, which means if I do something to the teeth, the joint will get affected. If something happens to the joint, the teeth will get affected. You know what is the connecting link in between? It's always the muscle. The muscle is the power source. Okay, and we all say, when does a problem occur? When there is disharmony. When is there disharmony? When you put an interference into the system. If you introduce a high crown, disharmony steps in, and there is hyperactivity of the musculature. Okay, very, 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 very common saying. If teeth go in war with muscle, muscle always wins. That's why we see so many dental manifestations of interference. If joint goes with war in muscle, muscle always wins. That is why we see so many patients today who are clenching and bruxing and are developing clicking and dysfunction of the temporomandibular joint. Friends, every occlusal therapy that we do should be targeted at achieving peaceful neuromusculature. How do we achieve this? By making sure that our occlusion is mutually protected. Dots at the back, lines in the front. Is it easy? No. Is it doable? Yes. It's not easy. Nothing is easy. If you commit to it, you will be able to do it. Everyone says that if I could do it, why can't you do it? I am human, so are you. You will only and only learn if you realize how important it is, right? Very simple key to success that I want to share with you guys. Please be patient. It's not like after this lecture, you go back in your patient's mouth and everything's going to be hunky-dory. It does not happen that way. You have to be patient. Please do not quit. Do not give up on occlusion. It is worthy of our attention, our time, our focus. Remember, patients deserve better. right? If they've trusted us, if they've come to us for their dental work, I think it's our moral responsibility more than anything else to give them quality dentistry so that their lives go on smoothly. More importantly, when I go to sleep, I can sleep peacefully knowing I have done justice to my patients. Quality over quantity. And friends, that is exactly the motto that I had when I sat down to script the books that you see in the market. And one of the images that I have in the book very beautifully describes my feelings towards how important the anatomy of a tooth is. It says the function of design is to let the design function. So beautiful. Remember, every slope, every cuspal incline, every sluice sway that there is, every marginal ridge, every incisal edge position, every cingulum, every individual facet of tooth design is years and years of evolution. Remember, survival of the fittest. So if there is a particular anatomy of a tooth today, it is because it is best suited to serve. And they always say tooth should outlast the human body. And that should always be our goal when treating teeth from a holistic perspective. Stop running behind aesthetics. Chase function. काबिल बनो, कामयाबी छक मार के आपके पीछे आएगी. Right, friends, I know a lot of you all have slight confusion about the second edition of the master volume, especially those who already have the first edition. So let me clear the air out a little here. First edition is the maroon color book that first came out in the year of 2016. As we added more content, we realized the book was becoming very thick, more than 700 pages. So what did the publisher do? The publisher split the book into two pieces. The starter volume that you see on the left hand side and the master volume that you see on the right side. The starter volume, friends, is black and silver. The master volume is black and gold. Both are black, so don't confuse yourself. Right? Starter volume is a part of the first edition. If you have the first edition, don't buy the starter volume, only buy the master volume, because master volume has a lot of new content, especially content related to occlusion and full mouth reconstruction, along with rubber dam isolation, which is an absolute need of the hour in the world today. Okay. If you want to buy both of these, if you don't have the first edition, I will strongly urge you to log into, friends, mikdental.in or contact this number, because there is an exclusive 10-day offer that is available starting today. We are all sitting at the brink of a possible lockdown. What better a way to spend time than to sit and enhance your knowledge? For those of you who are out there who value their time and who believe that this time should be used in the most prudent manner, bring this book into your hands, a new friend who will help pave through these difficult times. And believe me, we will do this together. As you read through the content, you will imagine as if I am reading the entire content out to you, because it's not scripted in a theoretical manner. It's not a textbook for you to pass an exam. It's for you to become a good clinician. And that's why the entire book, friends, is all about pictures more than text. Okay. Remember, these pictures that you saw in the presentation today, they all come from there. We've had an international illustrator come in and design these for us so that we can add that much more value to the content. And these are how everything is enlisted. Pictures after pictures after pictures. Not just aesthetics, but also function, especially full mouth rehabilitations, face bows, articulators, centric relation, vertical dimension, digital planning, ceramic, composites, implants, whatnot. 25 chapters, friends, more than 500 pages, more than 2,500 images, and more than 100 cases together sum up the master volume. If you want to do next level dentistry, if you're someone who's starting off, friends, for you, there is the starter volume that is all to do with crown and bridge dentistry. So you may choose whether you want to do simple basics or whether you want to do advanced. So if you want to do everything in prosthodontics, go ahead and call for the combo offer. These prices may never be available again. Friends, I cannot thank you guys enough for spending this time with me. For all those of you out there who have been present for all 3 webinars, my salute to you. You have showered your love and praises. Keep them coming. It keeps the fire going, especially at a time where things are a little difficult for all of us. Big thank you to the entire team of Abbott and the Indian Dental Association for giving me this platform, for getting all of us together and allowing us this opportunity to exchange our thoughts. I am so grateful to everyone behind the picture for making this possible. And I share with all of you all my best wishes for the times to come. Yes, times are difficult. They may get more difficult. But once again, remember, let's not quit. Because as they say, it's after the dark cloud that you see the silver lining. Friends, I'm sharing with you my personal contact, my email ID. I am available on different social media platforms. If you wish to connect with me, feel free to do that. I shall try to be there with you as we all hold hands and walk through this journey together. Back to you, Dr. Yogi.